Has anyone in the room got any questions for any of the panellists here this morning?
Just about the skin graft, is that actually happening now, or is that an idea that we want to do? And how long does the skin graft last?
Thanks, Gordon. Yes, they are actually occurring. So there's been some studies coming out from Toronto where they've looked at sentinel skin grafts, and especially in looking at the paired between the lung and the skin. There's also a new clinical trial that's just started over in the UK at Oxford, looking at this exact scenario as well. So we're hoping to chat to those guys and see if we can get some samples, because that would be terrific. The skin flap has been done previously as well. It's not just been done in the lung, it's been done for other kinds of transplantations, so facial transplants, limb transplants, abdominal transplants. So there is some history there. And it actually looks really good, because the skin seems like it's the primary site for the rejection. And if you can catch it early enough, then perhaps you can prevent what's happening in terms of the lung allograft.
There was this great speaker at TTS in Istanbul just now who's from the UK, and he had a complex multivisceral transplant. Like basically all of his intra-abdominal organs essentially were transplanted, including a large piece of skin, including the donor's belly button. And he had rejection diagnosed a couple of times based on changes in his skin, the donor's skin. It was really fascinating. It's really interesting, yeah.
It's absolutely intriguing and would be of great interest, but it's not happening outside a very small number of centres.
Thanks, guys. Zaki, great talk, guys. Two questions, one for Nicole. So do you think we should be doing a skin transplant for anyone who gets a lung transplant moving forward? And my second question is for Debbie. Really cool what the B cells are showing. Have you looked at any breakdown of the type of clad people are getting? Because you assume that people get restricted clad and maybe associated with antibodies, and B cells make antibodies. Why would that be people who've got less B cells?
Yeah, look, I think that would be a great introduction. I think it's really important, probably not so much maybe in the first year where you're getting lots of bronchoscopies coming in. You're monitored quite closely in that first year, but after 1 year, 5 years, 10 years, perhaps the skin graft and looking at rejection of the skin graft might be an indicator for chronic rejection. I don't know. It's not an easy thing to do. Obviously, there's lots of psychological things that you need to deal with as well, because you're looking at a hidden organ versus a skin patch, so you're looking at your donor tissue all the time, and you're looking for sites of rejection. So I don't know how logistically possible that is. All I know on the back, it's I don't know, it's like a tattoo. No, but they have done it also on the thigh region as well. So there are different sites available. I don't know about the logistics of doing it at every site.
To answer your question, the 13 patients that had clad in the study, the minority had RAS. It was 3 out of the 13. So it's a mixed bag of clad, if you like, that we're seeing this result. And I think it's a really good question, because I think clad can be complicated. And there's probably lots of other types that we're not really aware of at this point. And it's possible we are looking at sort of an early clad, because 3 years after the transplant is quite early. So it'll be interesting to see when we repeat this, if we can look later and extend the understanding. As to what type of B cells and what they might be, we know that it's a reduction or a loss of what are called naive B cells. So these are B cells that are yet to make antibody. So they have the potential, but it's the naive B cells that specifically seem to be missing. So yeah, as to why, we could hypothesize a lot, and it is part of ongoing work, but they must perform some sort of role in creating homeostasis in the beginning when you're given the graft, the transplant that comes in, and they obviously have an important role there for setting up how things may play out over time. So it's important to consider. I think this work is showing, in terms of an impact, that B cells are not always bad, and it's also been seen in kidney that if you give drugs that deplete your B cells completely, that does lead to bad outcomes. So it's not an entirely surprising outcome, but there's very few studies that have shown that B cells are important to sort of really have around at the time of transplant.
I'm just going to do one last question. There's one last question online. One of our patients actually said, I've had a bone marrow transplant prior to the double lung transplant. she's now 20 years post-transplant. Has the bone marrow transplant had any effect on the longevity of her post her double lung transplant?
Who should I pass this down to? This is a great question.
You presumably got elements of 3 different people's immune systems.
And her bone marrow donor was her mother.
Right. So there's still multiple people's genetics and HLA, as we've talked about there, and it's a very complex interplay. And some of these can be protective, and some of them can be trouble when they're mismatched. And some of the work ongoing is to show that sometimes a mismatch is actually good, not bad. And it's understanding all these various components of the way the body is designed to work. Mostly, all this is set up to fight parasites in cavemen, and so we're trying to understand how the complexities of each of these different systems. Yep.
Okay, and one last, probably very important question from one of the viewers online is, how many years before this exciting research, what everyone's talking about, makes its way into everyday clinical practice? How long's a piece of string?
I think the answer is a lot of these things have pretty rapid translation. Each of the talks has something that we could take home. Lucy's one is talking about tests that are available and that can be done and able to predict things in the future rather than waiting for the problem. Brad and Dimi were actually talking of the same thing. If you have troubles with your lymphocytes, you get infection and you get rejection. That's something that we can learn from sort of today. And Nicole is describing something that is potentially similarly applicable. If you can understand the troublemaker players, then you can start to plan your transplants and avoid them. So these are things that you get out there into the publications. You get out to get your colleagues tell you that they have found similar sort of things. And right at the start, I was saying that what's happening here is being heard around the world, and all of these speakers are speaking and telling others, and it feeds back, and they come up with ideas as well. So it's very real.
Well, I was just going to say the CMB guidelines meeting was really interesting, right? Because the last edition in 2018 didn't really talk about the lymphocyte count, it sort of talked about the quantiferon assays, but didn't really have specific recommendations on how to use them. But the updated ones are going to have really changed a lot, and there's going to be clear recommendations about these tests and how they might be used. So it's like real progress over 6 years, delayed by COVID, a little.
Thanks everyone to the fantastic speakers and the panel questions. I'm sure if there's any more questions that people have that are here today that they haven't asked, that would like to ask, or anyone online would like to ask questions, you can always email Wendy or Lungitude, and we can forward on to the researchers, and we can provide some good information back if there's things that you would like to know.